Good morning, everyone. Welcome to our webinar today on looking at the staffing mandate from all sides. My name is Rebecca Love. I am a nurse. I currently serve as the Chief Clinical Officer at IntelyCare, and I'm very excited to be joined by Janine Fink Boyle, the Vice President of Health Policy for LeadingAge. Janine, would you like to introduce yourself?
Sure. So good morning. Thank you, Rebecca. Thank you for having me today. So again, my name is Janine Fink Boyle. I am the Vice President of Health Policy and Regulatory Affairs at LeadingAge. And so I oversee our congressional and administrative analysis and advocacy for nursing homes, skilled nursing facilities, life plan communities, as you know them, that have nursing homes, as well as assisted living and independent living, and work on related legislative and regulatory issues. I present nationally for LeadingAge, as well as a couple associations and organizations that I'm on boards with, and really talk about federal policy and the collaboration and the connection in long-term services and supports for our members in the home and community-based services space, as well as affordable senior housing.
Wonderful. And for everybody who's joining us today, Janine and I are going to have an open and honest discussion around the topic of the staffing mandate. We want you to know that this webinar is going to be recorded and shared. And if you would like to engage in our discussion, we are going to be monitoring the chat for questions, or also you can submit them in the Q&A. I would like to talk to you a little bit about the current situation. As you were all probably tuning in, for the first time in decades, the Biden-Harris administration has put forward new staffing guidelines specifically around mandated nursing hours around the level of care which is occurring in long-term care. Janine, can you give us a little bit of the perspective from your organization as to why this mandate was proposed, and currently what is currently going on within your membership dialogue? And we can then discuss a little bit about how that's going to impact more of the frontline nurses and also the patients that are residing within these health centers.
Sure. So let's go back a bit and talk about the current administration and the goals that were set forth through the State of the Union in the last 2 years. And if you remember, 2 years ago, there was about 19 seconds with the State of the Union that was focused on nursing homes. And we really kind of dial that back to knowing that nursing homes were put in the spotlight during the COVID pandemic. So during that public health emergency, as nursing homes followed through on taking care of the most vulnerable population, we know that there were lots of challenges that nursing homes had. And one of those challenges was staffing, whether that was during the lockout and when doors were shut and there was no visitation and staff were sleeping on the floors of their organizations, or when the doors were open and staff decided to retire and leave long-term care services and supports, nursing homes in particular, we know that there have been some staffing challenges. So from all of that, the Biden administration kind of put forth, and what you saw in an executive order that came out earlier this spring, was a real focus on the quality and safety of nursing homes, taking care of residents and person-centered care. And so from the standpoint of LeadingAge, our members are mission-driven organizations. So the majority of our nursing home members and our members at large are not-for-profit organizations. And so their fiduciary responsibility is from a board. So there's not trustees or individuals that are owners or investors in the organization. And so instead of putting a lot of those dollars back into what you would consider more of which you know as a for-profit organization, our mission-driven members and mission-like organizations actually put their dollars back into their own organization. And a lot of that is focused obviously on the quality of care, quality of life of the residents, as well as staff enhancements and staff recruitment and retention. But what we've known is that over 200,000 individuals left the long-term care workforce during the pandemic. And so, with that, we've seen that our members have had to make some difficult decisions. And some of those decisions have been the aspect of changing service lines, meaning that they've closed neighborhoods or what we know as nursing units. They have had to stop some admissions from acute care and home and community-based services because they want to be able to staff according to the acuity and the residents that they have in their occupied beds. And so they've changed their bed capacity or their census. And so that's been a challenge. They've gone through different lengths of trying to recruit and retain staff. But what we've seen is that there really is not a pipeline. And what we hear from members is that not just during the pandemic, but now as we're recovering and being resilient moving forward, our members are finding that a lot of the nursing schools, whether it's nursing assistant, whether it's licensed nurses, are not there anymore. And there's not clinical sites available to them. And so they're not graduating and bringing in the individuals that could start in an organization. And then on the flip side, as people are leaving, the staff that is staying is looking at their retirements.
It is a really interesting time. And Janine, I have to tell you, through the pandemic, I think we all watched as the world unfolded what was going on in long-term care. And to your point, the State of the Union addressed what was an absolutely devastating situation. 200,000 employees, as you said, left long-term care during the pandemic. And although that we've seen a rebound of nursing workforce in almost every other setting, you're talking about hospitals and ambulatory spaces, long-term care is still dragging in this space. It's still lagging behind the rehiring efforts, although we are hearing some very good numbers that full-time hiring is hitting. I think one of the things that addresses what's going on, and I am a nurse in full disclosure, we know we've talked about this before. I have been, based on all the research, I know one thing is certain, which is when you have more nurses and you are driving care, outcomes are better for patients overall. And it feels to me like the Biden administration has put forward a proposal to increase the amount of hours of direct care by nurses. And I think one of the areas that is area of concern in this current legislation, though, is there's two types of nurses in the United States. There are LPNs or LVNs, which is a one-year nursing degree program, largely graduated through technical nursing schools in the country, versus an RN degree, which is a minimum of a 2-year or associate degree nursing program. And the largest workforce working in nursing homes today of nurses are LPNs. And the truth is, though, the entire current proposal leaves out the entire LPN workforce. So why do you think that occurred? And what is the questions being asked by your members around how to manage LPN hours within regards to this current legislation?
So we'll start with that. There really is not a definitive answer to why LPNs were left out. So I think as probably everyone is listening to us knows how CMS has come to put this proposed mandate together. And there was a consulting group called Abt Associates that was contracted with to do a study on nurse staffing. And so for about a year and a half, Abt Associates did qualitative and quantitative research. And part of that included actually doing site visits through rural and urban nursing homes throughout the country. Some of our members were part of those site visits. And what they did is they had a pretty narrow focus on what they were looking at. And when you look at the research in the study, which I think everyone knows was leaked prior to the actual proposed mandate that was put into the proposed rule through the Federal Register, when you actually looked at that study, you saw that they equated that LPNs didn't have any quality of life or quality of care for staff. And they looked at discharges and looked at rehospitalizations, but didn't really dig down deep in what we know as care planning, assessments, the kind of day-to-day care that LPNs, and I'll just kind of give a little bit of my background. I was an operator, a nursing home administrator for almost 20 years, and have sat with the staffing coordinator and looked at how we were putting together our staffing mix and model from rehab to chronic care to our dementia unit, and really focused in on the fact that LPNs were our seasoned dedicated staff members that had been there for years. We would bring in registered nurses and they would stay for, a year or 2 years. But when you go back to the staffing study, it was really in black and white that they didn't really follow through on looking at LPNs. And what the concern is when we talk to our members and you look at the fact that there are over 30 states that have state staffing mandates currently, a lot of those state staffing mandates actually have LPNs as part of their mix, as part of their ratio. They might be counted as a licensed nurse, or they could potentially be counted in some states as a certified nursing assistant. And so there is precedent. It is out there in state mandates that LPNs are part of this ratio. And the concern is what will happen to those LPNs if this proposed rule as written becomes final. Because what we know is that LPNs are about, I think when you look at actual numbers, LPNs about 55 or older. They are women, and they are women of color. And so what will happen to those LPNs if an organization has to make a decision to meet a staffing mandate that doesn't include LPNs? Will they be completely wiped out of the staffing matrix and actually lose a position, lose a job? And I know some opponents on the other side, when talking about it, and talk about, well, let's get the LPNs trained and let's get them through a ladder and let's have them become a registered nurse. And believe me, I wouldn't not say that isn't something that should be done. I would relish in the fact that there is dollars in the proposed rule to go through HRSA and for training. We can talk about whether that's enough, but that would be wonderful. But let's dig deep down into LPNs and their background and think about how long they've been in organizations and have they been offered that before, and do they actually have the ability and the time to do it? That's the larger question.
And to your point, I'm a master's prepared nurse, but I worked in long-term care. I worked as a nurse on the floor of Little Sisters of the Poor. I worked with excellent LPNs. However, I think that the point of this study, which was shocking, was the studies really showed the advancement of care and outcomes when it came to RN hours, driving better outcomes. And to your point, the studies have not been done to necessarily show the impact that LPNs have on quality patient outcomes. And one of the very interesting things that I found most interesting, actually, about the proposal is that currently in the United States taxpayer currently already spends $100 billion annually on providing care within the long-term care communities. And this new proposal actually seems to suggest that there's actually going to be an increase in the 2024 budget to $150 billion that's going to be invested in this. So there's been a lot of discussion that there's actually not a funding mechanism that is being put into place to actually offset the federal floor for staffing levels. But I'd like to get your opinion on that, because if you're looking at the data as presented, it appears that there's actually a significant amount of money that is going to be added in addition to actual, as you mentioned, HRSA grants to underwrite nursing education for students that would like to advance their education in long-term care. But what is your opinion of the current way that this investment is being proposed, and why is there opposition to this, which seems like it's actually increasing the budget to address this transformative investment in care?
So I think that you have to dig a little bit deeper down, and a lot of the mechanisms of how that money is going to be distributed is not outlined. And so there's a big swath to give that number. But when you actually dig a little bit deeper, what you see is that there is home and community-based services, and that is a big push of the administration. And everyone should have the opportunity to age at home, to age in what they consider their home and their environment. But there has not been a particular earmark for long-term care or nursing homes. Now, we do understand that the $75 million through the proposed staffing mandate rule is going to be marked for long-term care or nursing homes. So we'll say it that way. However, again, those mechanisms have not been outlined. It's still what we were told needs to be worked out, and it is a proposed rule, so we can say that. But that money is going to HRSA. So HRSA is the agency that's going to actually distribute that money. But what we were also told, and what you can see right in the rule, is that those dollars are also going to be for surveyors to be trained, because as we know, there's a shortage of nursing home surveyors in departments of health throughout the country, which has caused a backlog of annual surveys and recertification surveys, as well as complaint and federally reported incident surveys. And so the concern is that there are dollars that are earmarked out there, but they have not been earmarked for long-term care. That home and community-based services is also a very big push of the administration.
No, thank you for clarifying that, Janine, because those are the questions that have been coming up with regards to it. It appears that a large investment is going on. And honestly, to that point, it is seeming like it is moving a lot of the care that would be traditionally provided in long-term care or nursing homes into actually supporting patients that would be at home. And to your point, the understanding of where and how care is delivered is something that I think the entire country is interested in. But in the interim, as this transition may happen, as we're moving more patients to reside in their homes, we still have acute needs that are going to be resolved by nursing homes. The question that I'm having along some of these things on this federal floor staffing is that some of these assessments that are coming forward is that they're really looking at registered nurses being on the site round the clock. There's also requirements of increasing the amount of registered nurse full-time direction of cares to about 33 minutes per resident per day of a registered nurse. And my question to you is, why is the industry at large opposing the needs to actually increasing the amount of registered nurse time within a floor, but also increasing from to 33 minutes per resident per day doesn't seem like a dramatic increase in the amount of care being provided by an RN per day. But could you give us some of the greater understanding of why this is seen as dramatic change in the current standards in the industry?
Well, so I think that there's a lot of different opinions and a lot of I think, understanding of what that actually will equate to and how that will equate to an organization that might have 100 beds versus then you have an organization that might have 500 beds, right? So this is kind of that one size fits all. And so that's part of the concern that we know that we've heard from our members is that it's not that there should not be an individual that has the license or has the ability and the assessment skills to make sure that the resident gets the quality of care and quality of life that's needed. And what we want to obviously avoid is any sort of rehospitalization, discharge to an emergency room for something that maybe a registered nurse could be part of and could be part of that care. But we really need to look at how that mix is put into place. And are there other physician extenders? Are there other individuals that can be part of that process that nursing homes are already using currently? And so why is it that there needs to be another layer added onto it when maybe you already have the staff there? It's just thinking about how you can use the individuals that you're working with currently. And in the case of, is there an opportunity for some telemedicine, some technology? Again, I know that there is lots of opportunity that was used with extensions during the public health emergency, but why are we not looking at that also? Not just bodies in an organization to put to a number on a sheet.
I agree with you 100%. And honestly, one of the greatest advancements during the pandemic was the extension to be able to using telehealth as approved by the federal government within long-term care. And I think that's been transformative. And to your point, this entire initiative does not specify if that RN actually has to be on site. So to your point, there is a moment and opportunity for innovation to occur here. But the question that I also have for you is, you mentioned the vast majority of your members within your organization at LeadingAge are mission-driven or nonprofit. And the Biden administration's report says currently 2/3 of all nonprofit nursing homes meet these requirements as is. But they have a direct suggestion based on a working paper that they had put out that examined over 18,000 home facilities between 2000 and 2070 that found that private equity ownership of nursing homes had led to an increased excess mortality of residents by 10%, increased prescription of antipsychotic drugs for residents by 50%, decreased hours of frontline nursing staff by 3%, but an increase to taxpayer spending per resident by 11%. And they basically said the impact overall was that the study implied an additional 20,000 lives were lost as a direct result of private equity-backed nursing homes. So my question to you is, why is there this discrepancy between what we're sort of seeing by the nonprofit nursing homes versus potentially private equity-backed nursing homes? Where is the divide, and how can we resolve basically statistics and studies that are showing such discrepancies between those settings based on ownership structure?
So I think that, if you go back and you look at actually where you kind of like follow the dollars and you see where the dollars are going into, and you look at some of the organizations that have private equity, there might be more of a couple of different organizations that might use those private equity dollars in different aspects. And so the nonprofit members or our mission driven members, they don't have that other line, right? So the dollars that come into their organization are expended on what's going on in their organization. There isn't another entity that needs to be maybe paid back or might have other services and supports that they might be using. It comes all back into the organization. Sorry, I live in Washington, D.C., so you never know who that could be going by. But what we've seen is that there's a lot of questions about how those dollars actually get spent. And as I said before, there are investors, there are owners, and so part of that again is following the dollars to where they go. But our members, what they're looking in, and everyone receives, if you're in a state, you receive the same Medicaid rate, right? Everyone on Medicare is under PDPM. So again, on how you use your PDPM payments, depending on the diagnosis and the services that are used. But then, when you come to all of your expenses and you're looking at your bottom line, where are those other dollars going to? Whereas our members, we know that they're going back into the organization, whereas in a private equity, they actually have other outputs, I guess I should say, of those dollars. And it is difficult because I do know that there are for-profit members or for-profit organizations that have amazing organizations, amazing facilities, taking care of their residents, and but there are, as we know, there are some bad apples out there, and there's some organizations that are not putting the dollars back into the organization. They're not putting the dollars back into the bricks and mortar. They're not making innovative or creative opportunities for residents. And I think the most important aspect of person-centered care, obviously, is the care, activities of daily living. But the other part is the engagement. And so it's most important dining, so food and activities. And so really, looking at organizations, again, a 1960s building might need some work, right? Might need to have some physical environment, capital improvement. But again, what's going on in the building? And so that's where you kind of need to see what organizations are doing and and the flow of dollars.
And Janine, I was listening to a panel the other day with the chief technology officer of Microsoft, and he said what was interesting, and he sort of explained to me the difference between the role of the organization of a business, which a business always will be swayed by profit, but the role of government is really to always do what's in the best interest of the people. So I think, to your point, that we're coming into this alignment between, if federal taxpayers are underwriting the bill along these lines, do we have a right to actually mandate that a specific level of care is provided within these organizations? But a lot of our audience is even chiming in right now to say that their current workforces are being supplemented by staffing agencies. They don't have enough full-time hiring. And I'm wondering, is there a difference right now between what you're seeing between nonprofits, your mission-driven organizations, versus for-profits with regards to hiring? And are one doing better than the other? Do you feel like this is coming back? Do you feel like there's been a turn within the ability to hire? Is it a regional situation? Have you seen any bright spots within regards to this? Because absolutely, I think fundamentally, historically, staffing agencies had only been used for a stopgap. They would only been historically used at 3 to 5% within the long-term care industry to cover, leaves of absences that were generally one of those flux that happened within the industry. But during the pandemic, staffing agency use could have gone up as high as 20 to 25%, which obviously created for operational dysfunction or challenges financially for these organizations. So what are you seeing, and what kind of advice could you give to the people here who are saying, look, we're using travelers at $60 an hour. Why are they not just putting that money to the workforce and paying them more within the regions that they exist?
Well, so I think that, part of it is that if you're in a nursing home and you're operating a nursing home as administrator, director of nursing, your board, you're there for a reason, right? You're there no matter when we say, mission driven. But I think overall, the 15,000 nursing homes in the country, the majority of them are there because they want to take care of the most frail and vulnerable older adults that need this care at the end of their life. And so I think where we've seen with our members is that they've had to make a choice, and they want to be able to keep their doors open. They want to be able to stay in the community. They want to be able to make sure that people have jobs. And so they've had to go to agency. Now, we have seen a drop, but I will say that there are some very creative agency organizations out there that are helping some of our members actually bring in a traveler, but then work with them to make them permanent. Now, when I say traveler, I mean ones that actually are in that same region and in that same state, in that same community, not one that's coming across the country.
That just usually is contract labor, because that's actually, traveler is actually a defined mandated term. But just to clarify, within a 50-mile radius, that's exactly what you're saying, but just so that the audience doesn't get confused.
Thank you.
And I think that's actually, I think most staffing agencies, in full transparency, I think that is the goal of trying to develop better partnerships. And I think that many of these people are tackling long-term care with the effort that this is a crisis in our country. And if we have the greatest generation residing in these nursing homes, then they deserve access to care and actually having staff that is going to provide that care. And I have to tell you, I mean, the stories that we hear of what it is like in sometimes these scenarios of walking in, they are still very difficult, right? There's still is a lot of our clients clients or the audience has actually put forward is, the truth is there's not enough care providers in these settings to do all the things that are required. And I think it comes back to an example of, you go into a restaurant and you have a nurse who has you have a waitress who has a 1 to 12 table assignment. Suddenly you give them 1 to 24, you realize things are going to be missed. Quality is going to go down. And I think that somehow we've missed this connection in healthcare for a very long time. And I can say from my own opinion, ratios seem to be the only thing that guarantee there is going to be care provided. And that if you leave it up to the industry, profits are going down to that bottom line because nurses are a sunk cost to healthcare systems, to nursing homes, which means that more nurses just equal more cost. You can't say, okay, I'm going to bring another nurse in and I'm going to be reimbursed for bringing another nurse in. It's just more cost. That is a fundamental failure in the reimbursement model around nurses and CNAs, not only in long-term care, but in nursing homes. And this is something that has to address. And so you guys, we're going down to our last 4 minutes. We'd like to open it up for some questions. There hasn't been any that have come in the Q&A. There's a statement here that says by Richard, SNF RNDONs can make more income working as an agency nurse in hospitals with 3 to 4 days off weekly and have no call during usually staffing issues during their days off. What do you say to nurses who are saying, you know what, you're right, long-term care, the real competition is actually the hospitals. I should be working in a hospital, not in long-term care.
Right. I mean, I think that is very true. I think that that there are acute care hospitals that can offer bonuses. They can offer quarterly incentives, whereas nursing homes can't. So let's go back to what the core issues are. The core issues are, one, reimbursement, right? So we need to really look at the fact that we do not have any reform in long-term care services and supports in a reimbursement system. But let's look at what we're using now. We're using a Medicaid system to pay for long-term care for chronic care in nursing homes, which was not what it was created for, right? And then nursing homes are using their rehab units, right? And they're have these amazing units where they're helping people get better within 100 days and be able to go home, but again at a higher cost, right? So let's start and go back to the fact that there really needs to be a serious look at the reimbursement system. And I know that there are some states throughout the country, Midwest, West, that have increased their Medicaid rates there, but let's see how long did it take, and is it actually really covering the cost of care? Some 70%, some 80%. And so there really needs to be a shift in the mindset of our lawmakers and our policymakers about how we are paying for and looking and deciding on what is important to the country. And that's one. And then the other, as we've talked about the proposed mandate, the other definitely is the workforce as a whole. Why was it that you just said, Rebecca, that people don't want to work in long-term care, right? I mean, you and I are a little bit different talking, and I'm sure most of our audience, right? Because that we're kind of what I would say preaching to the choir. But I have high schoolers, right? And I have a child who did volunteer work in a nursing home. Now, I'm not sure, as he is, in the middle of high school, if he's going to go into long-term care, but he got his hours for volunteering. And, how easy is that? It's, again, certain things they can do, certain things they can't do. And I understand that. But, how do you open up the eyes to a younger generation? How do you work with some individuals that might have an interest or have a friend that knows that they're doing it? And so you have to start in a small scale. And so we work with our members really on community-based grassroots. And try to really see if we're not just out there on the Hill and we're not just out there with the administration fighting. We're also trying to help you work in your community, because the more that you get out about your long-term care organization, whether it's to a high school, whether it's to an elementary school, whether it's to a church, in the community at large, you really start to get some people interested, and maybe that could be part of your recruitment.
Changing behavior is absolutely necessary, as you said, Janine. Quick, rapid questions real quick. Does this apply to facilities with intellectual disabilities?
The proposed rule?
Yes.
Is that what they're asking? My understanding is no.
I understand that too. The other question is how are these nursing home administrators and owners being held accountable for patient harm that is resulting from poor staffing? I think that speaks to currently there is a shortage of auditors that are going out and doing those things, but there are careful investigations. But do you want to speak to that real quick?
Yeah, sure. So I do know that some state agencies that don't have enough surveyors are actually contracting with consulting groups to go in and survey. So their highest priority for survey is complaint federally reported incidents, any harm, immediate jeopardy. And so those organizations are being surveyed, and then they're actually being penalized when it comes to whether a CMP, so a monetary penalty, denial of admissions, and potentially down the road of being revoked from Medicare and Medicaid payments.
So lots of questions. How can you get involved? How can they get involved to actually influence this? And then we're actually at time.
So I will say that from LeadingAge, we actually have been working with our members, and we will work with anyone that wants to help make a comment. You can make a comment until November 6th on the proposed rule. It doesn't have to be a long white paper. You have the ability to go through the Federal Register. You can use our action alerts on leadingage.org on our website. And you can comment on one part of the proposed rule, because Rebecca and I didn't even talk about the fact that there's many other aspects of that proposed rule that do have some challenges. You can have 2 or 3 sentences. You can have your board. You can have your loved ones comment on it. It doesn't have to be one per organization. And so every single comment that goes into the Federal Register has to be read and analyzed by CMS. And once they do that and they come forward, then they could either make changes. And so you'd be part of that historic monumental process of before a federal rule becomes final. And so I would say, if you have any concern, make a comment, create a comment. And what we would say is we want the administration to get it right.
Thank you, Janine. And for those that we did not get all to your questions, there is conversation that we may actually open up for a panel to have some questions directly asked to us directly from the audience in the course of the next week. We wanted to set the table for you, get some high-level discussion going. Janine, it was just a pleasure spending this last half an hour with you. It flew by, and we hope that we'll answer some of the high-level questions that we had with you all. It is being recorded. We will send out this on a future date, and please tune in on future webinars. Thank you, Janine.
Thank you for having me. Have a great day.